Hey guys, I'm back. So getting back to informant number two, a lot of his concerns were related to the unique perception the EMS has by going to these patients' homes. Um, he's saying that they really are uniquely positioned to respond urgently in community and collaborate with physicians in their established system, and that they can kind of translate that over into some of the non-emergency preventative care, community paramedicine type things that can come up, especially with the heart failure population. His primary concern was funding, which kind of relates back to some of our advocacy discussions earlier. So, top three community diagnosis for this area: lead kinase at increased risk of heart disease, based on the persistent prevalence of heart disease as a chronic bleeding illness and cause of death. Affordable and convenient access to medical care can differ based on municipalities in the county, thus causing a potential disparity, as evidenced by the information we got through the windshield surveys. And then adults in the county are potentially at increased risk for cardiovascular disease, including heart failure, as evidenced by prevalence of smoking rates higher in Lehigh County versus other counties, especially nationwide averages, and higher than neighboring Northampton County. So the prior community diagnosis we selected was the adult heart failure population of Lehigh County is at increased risk of heart disease, as evidenced by the persistent presence of heart disease as a leading chronic illness and cause of death within the county. Our goal: to prevent an evidence-based education plan to community paramedicine providers, introducing the benefits of high-intensity home visits, promoting the prevention of readmission and improvement in treatment regimen, as well as in quality of life for the adult heart failure population. To do this, our interventions, overarching intervention is the integration of post-discharge and wellness visits in the home, specific for what we talked about, multifaceted collaboration of high-intensity home visits and person-to-person contacts, being successful in prevention of 30-day readmission rates. So really the goal is to try to utilize this mobile integrated healthcare team in order to provide some education to these patients. So primary objective was development of educational presentation with the paramedics, introducing them to the heart failure zone tool that we discussed earlier, as well as the high benefits of high-intensity home care through collaborative multidisciplinary teams, including the paramedics. And our secondary objective was identifying a project scope and implementation timeline for integration of community paramedicine documentation into the primary EMR for the supporting health system. Basically, we wanted to make sure that if the paramedics are going in the field, what they document and what they see can be seen in real time to the physicians and other providers in the team. Education project, we created the presentation using that zone tool for the EMS providers related to advanced assessment, as well as kind of how to teach the patients how to use that tool. Potential resources, obviously human capital. From the EMR side of things, information technology resources. From the EMR side, we weren't able to necessarily implement the link between EMRs simply because of actually change in prioritization of the IT teams of the networks during Epic launch. So we actually had to scale that back a little bit, but really a lot of the focus was getting the education implemented, which we were able to do through cardiology service line leadership as well as emergency medicine leadership. Barriers and challenges, initially we said funding would have been potentially one. Luckily we were able to dovetail with an existing MIH program that had a little bit of grant funding through an internal hospital grant, and they were able to utilize some of those providers in providing the education. And then from the IT perspective, what ended up being a barrier was not having access to the IT team just because of their rollout of Epic. Team members, cardiology physicians, mid-level providers, EMS medical directors, emergency departments, all of which we were able to sit down with and actually get some good buy-in for. Key stakeholders, the patients themselves, EMS providers, administrators, community paramedic providers, cardiology providers. We were able to get a good number of community paramedics as well attend the education, which definitely helped. So here are my references. Thank you very much.